The ankle or talocrural joint is a synovial hinge joint formed by the distal surface of the tibia and fibula and the superior aspect of the body of the talus. The distal tibia and fibula are joined by a strong fibrous interosseous ligament forming the inferior tibiofibular joint. There is additional support from anterior and posterior ligaments. The interosseous membrane provides strength superiorly to the joint. It is supported medially by the strong and thick deltoid ligament. The lateral aspect of the ankle joint is supported by the anterior and posterior talofibular ligaments and also by the calcaneofibular ligaments. The ankle joint is innervated by the deep peroneal and tibial nerves, branches of the sciatic nerve. Important muscles acting on the ankle joint include the gastrocnemius and soleus via the tentocalcaneus or the Achilles tendon. Also, the tibialis posterior, flexor hallucis longus, flexor digitorum longus, tibialis anterior, extensor digitorum longus, and the peroneae. Its movements are dorsiflexion and plantarflexion. However, in plantarflexion, a degree of abduction, adduction, and rotation are also possible. Let us begin the examination of the ankle with general observation, again noting any congenital or developmental abnormality such as pes plenus, the tibial length, and fusion. Note whether the foot is held in pronation or supination. Also, note the state of the medial arch, any angulation of the Achilles tendon, and any evidence of thickening or swelling. Then continue with palpation. Identify clinically important or dysfunctional structures like the malleoli, the joint margins, and the lateral and medial ligaments. Feel the synovial sheaths and tendons of the lateral and medial supporting musculature, the Achilles tendon and paratendon, and the sinus tarsi. To evaluate the integrity of the vascular supply to the area, palpate the posterior tibial and dorsalis pedis arteries. Then continue with general palpation of the associated muscles. Feel the calf muscles, the tibialis, the peroneae, and the intrinsic muscles of the feet. Note any wasting, flaccidity, or hypertonicity. Now, with the patient supine, ask them to perform active movements, which are plantarflexion, dorsiflexion, inversion, and eversion. Note the range of movement achieved and any crepitations or pain. Before performing any passive movements, as always, inquire about the presence of pain. Support the distal tibiofibular joint and with the other hand, cup the calcaneum. Move the talocrural joint through plantar and dorsiflexion, inversion, and eversion. Then evaluate the amount of anteroposterior movements. By applying force downwards through the tibiofibular joint, anteroposterior shearing can be tested. Then reverse the direction of force to test for postero-anterior shearing. From the same position, assess active resisted movements. Hold the patient's foot in a neutral position. Ask the patient to perform dorsiflexion, plantarflexion, inversion, and eversion, whilst you offer resistance to these movements. Note any weakness, pain, or abnormal sounds from the joint. If you need to assess some common functional movements of the ankle, you may wish to ask the patient to stand on one leg, to stand on their toes, then walk tiptoe, then on their heels, to climb some steps, to walk around the room, to squat, and to kneel.